So I wanted to tell you a little bit about my story in palliative care before I jump into any of the science or research that we've been working on. And my story includes two key individuals. The first was my former chair at Northwestern University, where I was faculty for the first 14 years of my career. I trained at Stanford for residency and fellowship, and then I went to Chicago, where in 2003, where my new chair brought me into his office and said, Mike, do you like old people? And I said, yes, Dr. Adams, I like old people. Because what are you supposed to say when your chair asks if you like old people, right? And he said, well, have I got the grant for you? And at the time, there was a grant being put into the National Institutes of Health to create the EPIC-EM project. And EPIC, the Education in Palliative and End-of-Life Care, had already been a funded new course created at Northwestern for really practitioners of any specialty to teach them core palliative care domains that they could take back, whether they were an oncologist or a surgeon or an obstetrician. And there was a movement to start to specialize EPIC into specific subspecialty domains. So they wanted to have EPIC-EM, they wanted to have EPIC-O for oncology, and this has grown significantly. You can essentially find a variety of the EPIC course for whatever subspecialty that you're in. But these were going to need to be funded projects that would take many years to convert the curriculum and specialize it to individual providers. So this is what this particular grant was for, and they were creating this grant at two institutions in the United States, Northwestern University in Chicago, Illinois, and Emory University in Atlanta. And the folks at Emory were driving the project, but they needed a person at Northwestern to be the point person. And at that time in my career, I was new. I had trained in emergency medicine, and I did a medical education fellowship. My career was going to include medical education research and program administration. And I really didn't think of myself as ever caring much about palliative care. But this is sort of how I got involved. My chair tapped me on the shoulder and said he needed someone to get involved. And what a wonderful journey it was to get involved in this grant, put it forth, get it funded by the National Cancer Institute, and then spend 4 years of a funded grant and a year of a no-cost extension to write an entire conference textbook, to prepare a conference, and then to do many of the interventions that I'll talk about as this hour goes along. The other important person in my story is my mom, who during the time of this grant became ill with breast cancer. So my mother was an emergency room nurse, and my dad was a firefighter, and I grew up in upstate New York. No one was a physician in my family. There was really no one who had gone to college until my mom got her bachelor's of nursing at nighttime when I was a child. She went to night school and got her bachelor's, and we were all very proud of her. I remember going to her graduation when I was 8 years old, and I thought she'd graduated from Harvard. I was so proud of her. She graduated from night school in nursing. And, certainly the influence of a firefighter and an emergency nurse was significant. When two public servants, get together, they make an emergency physician. So that's sort of how I came to be. And my mom, shortly after I moved back to Chicago, came to visit and shared with me that she had just had an abnormal mammogram and began her what was a 4.5-year battle with breast cancer. And this was a very sad but poetic time. I was typing a 400-page textbook on emergency palliative care at the bedside of my dying mother, who was going in and out of inpatient units who provided end-of-life care, what we'll call hospice units. And I'll talk about the hospice program in the United States in a minute. And I learned to be a better doctor through my mother's death. I learned how to take care of patients at the end of life in a much more nuanced way, because I was the one sitting at my mother's bedside titrating her medications. So between these two individuals, I really was driven into a field that I had no intention of going into. One person tapping me on the shoulder to do scholarship, the other person needing my care. at the end of her life. And I think both of those people have been important individuals in my journey towards this topic. And I struggled with my mother's end-of-life care in the context of a really famous Gallup survey. Gallup is a polling company in the United States, and there's many Gallup surveys about all kinds of topics in the US. And when I was a medical student in the mid-90s, a famous Gallup survey was put out that's quoted all the time. And it asked Americans where they wanted to die. And in this survey, the majority of Americans wanted to die in their home. And you would think that this would be a normal response to a survey question such as this, but it reflected a stark difference between the experience that most of us have in the United States, which is not having our family members die in our homes, but rather most folks dying in hospitals and institutions. And this is very different than the entirety of human history to this date. Prior to perhaps the 1940s and 50s in the United States, all humans generally died at home in their clans or their tribes or their families' homes, and or in battle. And that was the human death experience. And beginning in the United States in the 30s, 40s, 50s, there was a shift to the institutionalization of death, that Americans, as they were becoming ill, would be admitted to American hospitals, and they would be admitted to American hospitals for very long periods of time, for very simple illnesses or injuries. Childbirth would be a several-week hospitalization in the United States quite routinely in the 1950s. It certainly isn't now, but because of that, we as a society got used to dying in hospitals. And I remember my mother in her final months of life made it very clear to my father and I that she wanted to die at home. And this was supposed to be a gift that we were going to give her, because, and an unusual one, because most folks in the United States, in fact, weren't going to die in their homes. I'll let you consider this question briefly before I advance the slide. How many Americans, by percentage, do you think actually get to fulfill their end-of-life wish to die at home? Think about that for just a sec. And the answer is 80% die in hospitals or institutions. So only 20% get to die in their home as they would desire, despite 90% of Americans wanting that. And I would argue that we as providers need to be able to meet our patients' preferences at their time of death. This is one example of a patient preference that I think is a stark one in the United States, that folks simply don't get to die where they want to die. But I think that you could extend just the preferences question to a whole host of different end-of-life goals and suggest, at what time will decisions be made about my end-of-life care? By whom will those decisions be made? Will those decisions reflect my authentic choices and my preferences as an adult through the majority of my life? Is there a self-authenticity element to this that gets to be rewarded and valued and validated at the end of my life? Or will my preferences be ignored and I'm going to die according to the wills and means of a system or a group of other physicians or a group of family members who perhaps don't truly understand me? So this was a struggle for my father and I. We were able to keep my mother at home using the American hospice system to provide a hospital bed and, in the end, 24-hour nursing for several weeks and medications and the things that would allow her to be comfortable in her own living room before she was to pass.